All right, welcome to the Lumbar Spine Injury 101. I'm Dr. 𝘵𝘮𝑚𝑎𝑡. Those of you that don't know me, I am the creator of the 𝑃EEK method and the founder of the Soft Tissue Revolution, where we teach massage therapists a new treatment method that focuses on working smarter, not harder, allowing them to make well over $100,000 per year with less than 20 hours of time per week in the clinic. These webinars really kind of get you to the idea of like thinking critically and figuring out a problem. So let's jump right into it. So I start all these webinars the same way. How can you ever fix a problem if you don't know what it is in the first place? This is missing a lot in musculoskeletal care. People just kind of treat based off what they're trained in instead of what actually is going on. So our goal first is to know specifically what that problem is, because we can't fix it if we don't know what it is in the first place. So the goal of the 𝑃EEK method first is to get to a tissue specific problem list. Number two is to restore range of motion. Number three is to manage the load of the client. Number four is to balance the strength. A lot of times that's what corrective exercises. Once we've done everything, then increase overall strength with more global movement. And then lastly is just maintain that range of motion. Once you keep it clean, people do need maintenance. They do need follow-up treatments to keep things in a good place from where we are. So we're going to focus specifically on the lumbar spine. And the way I'm going to break this lumbar spine is going to be basically from the T12 spinous process all the way down into the bottom part of the external rotators where the sciatic nerve comes in. I have past webinars where I go a little more detail about these. I'm going to talk to these in like the context of like 7 problems: a bone problem, cartilage problem, disc problem, ligament problem, nerve problem, soft tissue problem, and tendon problem. I will link those up in the notes below. That goes into more detail about the 7 problems. There's only 7 potential problems in musculoskeletal injury. So if you haven't watched that one yet, maybe go back and watch that, because that'll give a little more context from here. We're going to break those down a little more in depth through this webinar. I've made webinars before about asking the right questions, so I won't go through this too much because this is just a review of that. I have a webinar called the 12 questions you must ask, because you can't start treatment until you know what it is. So it's going to be their age, their sex, where do they feel the pain, what does the pain feel like, how severe is it, what's the worst it's gotten, what's it's been over the last 30 days, what can make it worse, what helps it feel better. Those are my first order questions. I need to know those before I can ever start thinking critically about what's going on or applying a treatment. I also have the second order history questions. Is there any accidents or trauma? Any imaging done? Have they seen any other practitioners? What did any of those practitioners tell them was wrong? Did any of those treatments actually help? Do they do any working out? What do they do for work? And then I ask them how it's affecting their quality of life. The other webinar goes through that as well. Basically, what we're going to find today through this webinar is I'm going to break these questions down and put them into the different categories of the 7 problems and what it'll present with when you start to ask those questions. So let's get right into it. First one, bone problems. Bone is something that can cause some issues in there as well. Age is going to be a really big factor on that one. The older you get, the bones start to wear down. Trauma is also a big factor in there as well. Like if there's been a lot of falls, accidents, maybe they played a rough sport, they've been hard on their body over the years. This in turn creates some of that bone spurring in there. People know what bone spurring is, but basically there's this idea in the body called Wolff's Law. And the more force that you put into the body, the more it lays down bone. The body's trying to help in the short term, but those bone spurs can cause problems down the road. Another thing that we start to see is the joint itself, in between the lumbar spine into the sacrum. The joint starts to wear down as well. And there's these little things in between there called facet capsules that just get worn out. They're kind of like the shock absorber of your spine. And over time, those get beat up with that bone spurring, and those facets start to get really damaged. So bone is definitely a factor in a lumbar spine. Number 2, cartilage. Cartilage isn't directly correlated with low back pain because there's not really any cartilage involved in the lumbar spine. Technically, you could say the joint capsules have cartilage in there, but that's going to be pushing it too far. I will see cartilage problems secondarily in a hip issue. You know, as the hip gets worse, it can cause compensation in the lumbar spine. So knowing those 12 questions and asking the right way, you'll get a better idea of like, was this a hip problem first or a lumbar problem, or are they like hand in hand with each other? Next one, oh, missed it. Next one is going to be the disc. I call the disc the great mimicker of many injuries. You can see how long this list is. One of the key components of that is age, but I'm also starting to see this now in a younger population as they've gotten more sedentary, not moving as much, not as active, sitting a lot. we're starting to see some of that stuff in there as well. Next one's going to be symptom location, like where do they actually feel the pain? A lot of times disc can go all over the place. They refer these things called sclerotomes and go to different areas from where they are. Next one's going to be symptom quality. A lot of times people will describe those as like sharp, stabbing, aching, causing all sorts of issues in there as well. Next one's going to be severity. A lot of times with a disc, what I find is that usually when it gets really flared up and it's intense, like say somebody wakes up and they're feeling really lousy and they're like, oh, my back just went out. A lot of times that's going to be like an 8 or 9 out of 10. Provocative, like what makes it worse? Usually a disc feels better when it's not loaded. So when a person's like laying down, it doesn't feel as bad. Or say they've been sitting for a long time, they get up and walk around, it does feel a little bit better. Same thing with palliative. Usually what happens is when they're doing the activity, it feels worse, but when they're not doing the activity, it feels a little bit better. Accidents and trauma are really key here too, especially car accidents, lifting injuries, all that kind of stuff can cause some problems in there as well. Activity level too, you know, I see this both ways. So I see this in people that are way too active and do way too much. You know, they might be running 10,000 miles a week, cycling, working out, doing all that, but I also see on the other end where people aren't doing any activity, and that can beat the disc up as well. Occupation is really key here too. Like what do they do? Are they sitting all day long, not moving around? That can really inflame the disc and cause some issues in there. We also see this in people that are like blue collar workers that are using their bodies all day long and can put a lot of pressure on that disc as well. So disc, like I said, is a great mimicker of many injuries, but it shows up with a very predictable pattern. Like, hey, one day I woke up and I'm like 8 or 9 out of 10, it's sharp and stabbing. It feels better if I lay down, worse if I use it. That's going to really help you start to think critically about what's going on and knowing that the disc is a major component. Ligament is a big problem too. Usually with a symptom location where you're going to feel it, for this one is going to be from the T12 spinous all the way down to the sacrum. And what runs there is called the supraspinous ligament. And a lot of times people will describe that pain as like a tight or stiff. Severity, they're going to be like 3 to 6 out of 10. Not awful, but enough to get their attention. Provocative, it definitely feels worse as they start to use it. Palliative, it feels better when they rest it. Accidents and trauma are going to be really key here as well, especially if there's like a car accident or like some type of fall or slip. It really can pull that ligament very high. Activity level, are they doing too much? Are they doing not enough? It goes both ways, kind of same with the disc in there. When they're doing too much, those ligaments are constantly getting stretched and they lose their elasticity, which in turn can put more pressure on the joint, on the disc, on the muscles, all around there. And then occupation, are they using their body a lot, almost too much on a blue collar aspect, or are they sitting a lot? Because we actually see this a lot in that lower supraspinous ligament over time. When they sit, it actually stretches that ligament out and people don't really notice it at first, but sitting too long, now that ligament can't do what it's supposed to do, which is to support the spine. So instead of the spine kind of going like this, it actually creates like a nutcracker effect, which puts a lot of pressure, like I said, around the surrounding discs, on the fascia, on the joints, and the muscles. Nerve. There are 256 different places in the body where nerve entrapment can occur. They're very common. They're often missed because I talk about this. Nerves basically have to start at the spine and make their way through the rest of the body. They're built with like 15% of extra slack in the nerve itself to kind of keep it healthy. But over time, the nerves get stuck around the muscles, around the fascia, and it grabs on that nerve. It gives like that pinching type of feel. But a lot of times, this gives me an idea if I'm having a nerve problem, is like where they feel it. If the nerve is getting compromised, it has a very predictable distribution of where it goes. They'll describe it as like a numb, achy, burning, tension type of feel. It does feel worse when they actually use it. It feels better when they don't use it. Common areas where I'm going to find nerve entrapments for low back pain is really going to be in the sciatic nerve. And there's 2 areas where the sciatic nerve gets compromised. The most common is the sciatic nerve at the external hip rotators. It's not the piriformis, it's actually the deeper ones like the superior gemellus. And what happens is that nerve sits right over top and passes through there. And when we sit on it, it creates some pressure, creates some tension, scar tissue forms, and that nerve gets stuck. I also see it on its way down as it goes through the hamstrings. It can get caught on the lateral side and biceps femoris, but also cut on the medial side and semitendinosis, semimembranosus. I also will see a nerve entrapment on the front, not as common, but I'll see what's called the lateral femoral cutaneous nerve, and it actually gets caught in the hip flexors as it comes out. A lot of times I see that with people that sit a lot, maybe they've had some trauma, and that will kind of present with like some of that like more like numbness and tingling, not as painful down the leg, but nerve entrapments are very key in low back pain. Soft tissue, my favorite. It's the most common cause of pain, weakness, and decreased flexibility in the human body. It's also the most fixable with expert treatment. That's what we teach in the PEAK method, is finding and fixing scar tissue and restoring range of motion. This is a very long list. So where they feel the pain is definitely a factor. What it feels like, a lot of times they'll say it's like tight, hard to move, tension, things in there. Severity, usually what I find is the soft tissue kind of gets in that like 3 to 7 range. Provocative, when they use it, it gets a little worse. Palliative, when they don't use it, it feels a little bit better. Definitely trauma in there. Over time, trauma can build up and create a lot of scar tissue formation around there. Activity levels, once again, are they doing too much? Are they not doing enough? It needs to be somewhere in the middle. They're going to get that. Occupation as well. Do they sit on their butt all day? Are they up moving, doing a lot of extra like manual labor? That'll give that as well. I tend to find a lot of soft tissue components in the muscles and the fascia. They're involved in lumbar spine flexion. It's the most global motion in the spine, and they really get beat up. Another thing that I start to see as well is in the upper lumbar spine, you know, like from like L2 to like T10, I start to see some hypertrophy form in there. And what happens is that's just extra muscle that builds up because it's helping to ease the wear and tear. What we actually start seeing down low, especially in disc injuries, is some atrophy and some fatty deposits in the lower multifidus in the erector group. So you'll see like a outpouching of muscles in like the TL junction, and then you'll see almost like it just drops off and a flatness in there. That's some fatty deposits and atrophy that builds up as well. Tendon can cause some issues. Where I'm going to see the tendon the most is going to be on the proximal insertion on the ischial tube. That's right where those hamstrings go. Usually with a tendon problem, it actually feels a little bit better once they start using it, but then it's really beat up afterwards. And then palliative is like once they get off it and they let it rest for a while, it's not too bad. I see this a lot in people that have really high activity levels, or they're just working out all the time, doing a lot of sport activities like that. Another thing that I see in the tendon problem is like, how long has the low back been present? If it's been like a ongoing problem for years, what I end up seeing a lot is a tendon problem at the top there, because when the back is bad, what happens is the hamstring wants to come on and contract to act as a secondary stabilizer to the lumbar spine. And when that happens, the muscles don't get enough blood flow, they don't get enough oxygen, and it puts more wear and tear on the tendon. So what the body actually develops is called a tendinosis. So it's not a tendinitis, it's actually a tendinosis. And I talk about these more in depth, but basically, if we look at a tendon under a microscope, it looks like, if it's healthy, it looks like a box of like pre-cooked spaghetti. And it's hard to break, it's hard to snap. What happens over time with a tendinosis is it's getting more wear and tear in there. So what happens is it brings it, it puts more immature collagen fibers in there. And if we look at that tendinosis under a microscope, it kind of looks like cooked spaghetti. And it can't generate force, and those areas are much more likely to tear. So if you got these people that are constantly having hamstring problems really deep in the butt, most of the time it is a tendinosis. And a tendinosis will present with a couple of things. A lot of times, like, it doesn't feel too bad when they're sedentary and not using it, but once they start using it, it feels a little bit better, but then it's really beat up afterwards. It kind of has that arc where it might be sore just laying around, but if you get up and move around, it feels better. But then after that wears down, it feels a lot worse. That's how a tendinosis presents with. And 97% of tears were a tendinosis before they started. So it's really key to be able to figure that out and know what's occurring in your client. So common diagnoses that are completely wrong. One is just sciatica. It's the most common, what I call a junk box diagnosis. It's just like, I have sciatica. You know, people are like, oh, my back hurts. My damn sciatica is acting up. We always talk about, we have to have a tissue specific problem list. And if you just say sciatica, it doesn't really tell us anything. And that's what the medical field has really defaulted to, is this idea of like these junk box and just do whatever. But it's like, where is that sciatica coming from? Is it coming more from the back? Is there a nerve entrapment in the superior gemellus are down in the external hip rotator. So just basically saying sciatica doesn't really tell us anything. We need a tissue specific diagnosis so we know exactly where it is. Back spasm. So a lot of people think when a back spasm occurs that it's a problem with the QL muscle, and they'll go in and treat the QLs. They'll try to release the QLs. They think there's trigger points in there. The question you have to start asking yourself is, why is this muscle spasming? And what's going on? Usually there's an underlying problem in there, in the disc, in the ligament. There might be a nerve entrapment. There might be soft tissue involvement. So what happens is the QL engages in what's called protective tension. So protective tension is where those muscles tighten up to unload the spine. It's the same exact thing you do when you sprain your ankle. Your body knows to limp. That's what's happening there as well. So a lot of times what happens is the spasm is the effect, but it's not the cause. So if you go in and treat the effect, but you don't get to the cause, you actually expose that client a lot more. So understanding like, why are these back spasms happening, and trying to just get rid of the back spasm and then letting them go back to full activity, you really put them in a bad spot. And then lastly is lower cross syndrome. My criteria is anything with syndrome in it, in the diagnosis component, really is just code word for they have no idea what's going on. So this whole idea of like one muscle is inhibited and the other one's overworking, yeah, that might be happening, but and the glutes aren't firing and things like that. We have to ask the question of, why is this happening? And most times what is happening is certain muscles are shutting down. Your glutes don't just decide one day that they're not going to work or get what I've heard some people call like glute amnesia. They're not firing for a reason because they're trying to fix an underlying problem. So if you go right in, once again, and only treat the effect and don't figure out the cause, you can actually expose that client because you didn't get to the real problem. So think of like your disc and your problem is like your thumb and it's stuck inside a car door. The car door is all that scar tissue build up around there. You can't give this a chance to heal up till you remove that. So what happens is when you do these like quick neurological treatments, neuromuscular treatments, you temporarily get this window where it feels better. But any treatment that only addresses symptoms, not function, is dangerous. So then that client thinks they feel better, but now they're going out there exposed with those other problems, and they temporarily felt better, but you didn't fix anything. We always need a tissue-specific problem list, and all those listed above don't do that. Be better. Think critically. Know exactly where the problem is, what it is, so you can go in and fix it. So what are you going to see most of? Definitely scar tissue in the muscles, the fascia, nerves, and the ligaments. I'm going to see a lot of disc degeneration as well, specifically bulges and herniation. So how do we go about addressing it in the PEAK method? First is we just evaluate global motion first. So our first role is to see what flexion looks like in the lumbar spine, and also see how the hamstrings and the sciatic nerve are lengthening as well. Then I go in and check some rotation. Then we do manual and instrument-based scar tissue treatment to restore range of motion, and we directly treat muscles, fascia, ligaments, and nerves. We do manage the load of their disc because we have to manage the load in between, because basically when you have an injury, you have two components. You have load and you have capacity. Load is what they do. Capacity is what they can take. When they're injured, their load has exceeded their capacity. We're trying to fix their capacity. And if they're doing too much load in between, it's never going to get better. Next one is going to be corrective exercises to the lumbar spine muscles and the hamstrings. We need to balance that strength because a lot of times there's compensations in there, but it's only after range of motion is restored. We don't start with exercises before we clean up the tissue. It'd kind of be like building a house and putting the roof on first before you ever lay the foundation. That shit ain't gonna work. Next one is we're really big on breathing. So many people aren't using their diaphragms, they're not using their core to engage their breathing. And that's a big stability part of the lumbar muscles. We want to get in there and make sure we're doing everything to unload that disc. And then once the lumbar is cleaned up and functioning better, we do start to look at the lower thoracic spine, basically from like T11 to T6. I do some work in there in the deep erectors, in the intercostals and things like that. But we have to follow the process. There's an order of operations of fixing any problem. And number one, of course, is we need to get the bad tissue out of there and restore range of motion. If you try to start with exercises or neuromuscular reconditioning and stuff like that, you're missing that component. You're not setting that client up for success, and you're going to get those up and down results that never seem to last. Because at the end of the day, treatment needs to be three things: safe, effective, and durable. Most treatments are pretty safe, effective, maybe temporarily, but the durable component is what is missing from 99% of musculoskeletal treatments. We should be able to treat it give them some time off, and then we're still seeing those improvements in between. Thanks for watching. If you have any questions, leave them below. We'll be sure to answer them. Get access to our free training at the website listed below, and reach out to us if you have any questions that you want us to cover or you want us to go through. Appreciate you guys watching. Thanks.